You will see what is what is going on here, but it is very interesting. So this was the car accident on the highway, very tough one, and a woman with 52 years old, she was brought into our hospital, immobilized on a flat board. On admission, she was hemodynamically stable. As you can see, blood pressure okay, Glasgow Coma score okay, saturation was lower than before. Of course, emergency examination, CT scan by protocol, so CT of everything. And we have found, and not we, this was the patient from the department of Dr. Marinko Vucic that was before presenter here. So the rupture of the left diaphragm and herniation of the stomach and iliac flexure into the left thoracic cavity. The lung contusion, of course, so minimal left pneumothorax, partial spleen rupture, and then the rupture of ribs, the rupture of transversal process of TH7 and so on. So this was multi-fracture patient. The emergency operation was performed, repositioning of the stomach and omentum into the abdominal cavity, sutures, and repair of the spleen. And everything was okay. The patient was completely stable post-operatively, extubated, and fine, just fine. After the initial improvement in first 48 hours, in the next 12 hours, the patient was actually in hemodynamic collapse occurs and development of shock of unclear origin. So we didn't know what is actually the cause of shock. All we know that the patient was very hypotensive and vein necks were like swollen. She did not have any hemodynamic monitoring to help and to understand what is the type of shock, and I'm not sure that we will be able to put hemodynamic monitoring, you will see later. Of course that repeat CT was performed and pulmonary embolism wasn't found, but we found displacement of the heart and mediastinal structures into the left hemithorax. And also in the area of the transition of the left atrium into the left ventricle, there was a compression from the outside. And also there was compression on the truncus of the pulmonary artery. So the question for cardiologists younger than 40, not from Vinogradska, what might it be? Okay, we can go. So then I was called, this was my emergency TE. I have found the pressure load on right ventricle, paradoxical septum, very weakened contraction of the right ventricle, that was, the right ventricle was very dilated. It's very severe tricuspid regurgitation. And also I have found subannular compression of the left atrium. So we can call this subannular mitral stenosis. So there was a channel, I would say about 10 millimeters in diameter. When you put this in calculation, this was a circular channel that it would be about 1 centimeter square of flow. But if I also measured PhD, I got this, but I'm not sure that this method is reliable in this moment. And the pulmonary trunk could not be shown as well as on CT. The left ventricle was very small. The septum was shifted toward the left ventricle, and also so it was small and hypercontractile. So this was my finding. So we called cardiac surgeon, the smart one. Okay, and also then we have discussion: radiologist, surgeon, anesthesiologist. So 4 of us. And then we realized, on the basis that the patient has polytrauma trauma, chest X-ray following displacement of the heart, CT and TE, we realized that the patient has actually the circulatory shock because of laceration of the pericardium, and consequent, we call this, we were very happy because we invited this term, herniation and strangulation of the heart. We thought that we invited because I never heard. I was not the worst student in the generation, but I never heard about this. Maybe I missed the class this time. I don't know. But also the smart cardiac surgeon and the others, they didn't know for this kind of pathophysiology. Okay, so we decided to perform operation. But first, the question was from us, why actually the patient become hemodynamically unstable 48 hours after the operation? Why not immediately after the operation or immediately after the trauma? Because the assumption was that apparently the pericardial laceration was present from the beginning, okay? But that herniation occurred due to reduction of interthoracic pressure after repositioning, so after the operation, and after cessation of mechanical ventilation, okay? Maybe also it is possible that changing of the body position can actually provoke the herniation of the heart through the laceration. And also, we have to also admit that the right ventricle outflow tract of obstruction and dilatation of the right ventricle can also make the situation even worse than before. So emergency thoracotomy was performed, the pericardium was cut, the heart was liberated, the right atrium was darkened in color, but then recovered after decompression. After the operation, the patient was still with vasotropic support, in a state of shock, multi-organ failure, and she died. So obviously, all of this was too late. There was a period of 12 hours of worsening that we didn't know actually what is going on. What the literature said, so we have the series of patients 30 to 60 years ago, so before modern diagnostics, and isolated cases in today, let's say, last 10 years. So it's extremely rare diagnosis, and the survival rate is low. It can be seen more often as autopsy cases after the traffic accident, like in our patient, after blunt trauma, but also after penetrating injuries. But also, we should know that we have congenital partial defects of pericardium in 7 in 100,000. And that can also bring, at any age of the life, the patient can get like herniation and sudden death, okay? And also, it can occur in the patient, as you will see later, the pictures with epicardial electrostimulator in the newborn age because of some congenital block. But probably this will not cause this clinical picture. Maybe more it's likely to be like chronic heart failure, only acute if there is some other factor like arrhythmia. So mechanism and shock in patients with herniation is inflow and outflow obstruction resulting in hypotension, hyperperfusion. This is something that we call circulatory shock in this case. And with outflow of obstruction, the heart distends, making the strangulation even more. And you can see also the occlusion of the coronary arteries. You will see very nice picture from literature. So when we have to think on cardiac strangulation, when we have severe traffic accident, when you see on physical examination, you can see the maximal heart sounds or impulse into abnormal location. On the X-ray, you can see the shift of the heart silhouette to the right or to the left. And also you can see the pneumopericardium. So pericardium is actually the boring part of the heart, so nothing moves, you know. But my most interesting cases were with pericardium, like this one, pneumopericardium of the woman with that was spontaneous because of colon carcinoma. Okay. Also, you can have the sudden blood pressure drops. So, can you imagine the patient after traffic accident? You are taking her in the hospital or the patient, and then after some moments he will become hypotensive. ECG changes in electrical axis. And don't forget the herniation can occur later, like in our patient. TE can help, and also CT can help, but you cannot see the pericardium directly. So, and this was the problem also in our case. You can see that something is compressing your heart, but you cannot see what is this. So early the recognition is crucial for this patient, for every patient, and of course the surgery is the constant of therapy. Now you will see some other cases from literature. This is the case of 79-year-old patient with congenital defect of pericardium. You can see the shift to the left. You can see here the epicardial coronary arteries that are actually like cut here. So very, very nice picture. And you can see this also on CT here. Much nicer picture than ours. This is an operation. And now we'll show you also the case of 8-year-old boy after placement of epicardial pacemaker. So I don't know, 10 years. So 8 years after the operation, he has developed also pulmonary stenosis and mitral stenosis on echocardiography. So they call this strangulation of the heart, but it's not the same like in our patients. So these are the pictures that you can see, and also another report of also the similar picture you can see. So this was like picture that I have shown, but unfortunately I was not able to record this and to show you now here. But this is something that similar that I also have seen on my in my patient. Okay. So I found that this is about some emotional ones, but it can be applied on our case also.